The following podcast is part of a certified educational activity titled A Personalized Approach to Guide Risk-Adapted Treatment Decisions in Myelofibrosis, applying the latest clinical evidence on JAK inhibitors and novel combination therapies to improve patient outcomes, with Drs. Ruben A. Mesa and Naveen Pemmaraju. Access the entire activity and complete the post-test at peerview.com/CCY860. Downloadable slides are also available.
Hello, I'm Ruben Mesa. I'm the Executive Director of the Mesa Cancer Center at UT Health San Antonio, MD Anderson. And I'm joined today on this great discussion on myelofibrosis with my good friend and colleague, Dr. Naveen Pemmaraju, who is both an MPN expert as well as being the director of the BPDCN program at the MD Anderson Cancer Center over in Houston, Texas. Welcome, Naveen.
Oh, thank you, Ruben. Wonderful to see you and glad to be here.
Well, we're going to be discussing today a personalized approach to guide risk-adapted treatment decisions in myelofibrosis. We'll be taking you through some of the data, discussing new agents, and weaving this all through the setting of a real-world case scenario. So with that, we'll go ahead and jump in. So primary myelofibrosis, as defined by the World Health Organization, is a diagnostic criteria of both major criteria involving bone marrow findings of proliferation of atypia megakaryocytes, the presence of one of the driver mutations, JAK2 CALR or MPL, or including not meeting the WHO criteria for an alternative myeloid neoplasm. There's minor criteria that really are the clinical features of the disease: anemia, leukocytosis, palpable splenomegaly, increased LDH or leukoerythroblastosis. To have a diagnosis, you need all three major criteria and at least two minor criteria confirmed in two consecutive determinations. So really being certain that you've got the right entity and that there's the clinical phenotype as well. Now, as you're working these patients up, there's both pathology and molecular testing. You start with your bone marrow biopsy, trichrome and reticulin stain, cytogenetics, and then typically your MPN panel. That'll give you JAK2, and if that's negative, your mutations for CALR or MPL. NGS frequently we will be doing these panels as well now, particularly if we know they have an MPN. That'll give us both our driver mutation status as well as other mutations that might be relevant for prognosticating these patients. We've learned a lot over the past several years regarding the presence of somatic mutations and their impact on prognosis. First, those driver mutations, the CALR type 1 mutations having improved overall survival compared to perhaps the others, as well as individuals lacking one of the key driver mutations or triple negative having an inferior survival. And one of the reasons they frequently do have an inferior survival is an increased presence of some of the additional somatic mutations, of which several of which have an adverse prognostic significance. Indeed, ASXL1, EZH2, IDH1 and 2, SRSF2, all of these have some additional prognostic significance. Indeed, I just visited with a patient in clinic just before we began taping this, again with the ASXL1 mutation that seems to be one of the most prevalent and problematic. But there are others, including the presence of P53 and others. I view that this list will continue to grow as we learn more about the molecular phenotypes. Now, with MPNs, these patients have a very heterogeneous natural history. And because of this, there have been many different risk models that have been developed. As it relates to myelofibrosis in particular, there are several. There was initially the IPSS and then the DIPSS, the DIPSS plus, now the MIPSS, and even ones more specific to post-ET or post-PV, the MISEC-PM. Our NCCN guidelines acknowledge all of these different prognostic scores. They all have been validated. But as it comes to managing patients, it's probably still a little more specific than is necessary. In the NCCN guidelines, they divide patients up more in terms of lower risk or higher risk. and implications in terms of medical therapy versus transplant, and when to initiate therapy. So let's try to weave this in as it relates to a case. I'm going to frame the case, and then Naveen and I are going to talk about some aspects of the case. But let's say David is the patient's name. It's a 64-year-old patient, newly diagnosed myelofibrosis, 6 months of fatigue, night sweats, decreased appetite, weight loss. Spleen is enlarged, 6 centimeters below the rib cage, a little bit of anemia, platelets are 150, a little bit of leukocytosis, 2+ fibrosis, and is JAK2 mutated with a normal cytogenetics. Meets all of the 3 major and 3 minor criteria. This individual is considered higher risk. So as we continue discussing this case, what would you consider as frontline therapy? If you start them on therapy, what is appropriate follow-up and monitoring? Would you recommend using JAK inhibitors in the presence of a baseline cytopenia? Does it alter the course of the disease? When do we modify the dose? So these are all sorts of things that we are thinking as we are starting the prescription for a JAK inhibitor in someone who's an appropriate patient. So before we dive into some of these questions and get Naveen's input, let's just share with you a bit about the JAK inhibitor landscape now here in 2021. Ruxalidnit has been approved now for many years, almost a decade, as frontline in myelofibrosis, as well as second line in polycythemia vera. Fedratinib since 2019 has been approved as frontline in myelofibrosis, but certainly is also being used in second line setting as by our NCCN guidelines. There are several agents seeking approval, and furthest along in their development are momelotinib and pacritinib. Pacritinib with more activity, as we'll discuss, in particular safety for individuals with marked thrombocytopenia, and momelotinib, which also can help to improve anemia, each of them having some additional aspects of their mechanism of action that may be helpful in those groups. There have been several JAK inhibitors that have been tested, several of which are on the shelf, either due to toxicity or due to the competitive nature of this pipeline. Roxalidnit has been our standard for, now I mentioned, almost a decade. And there are multiple reasons for this. I think the effectiveness in improving spleen and symptoms, but over time we have learned, and it's been validated in multiple different ways, an impact on the survival in the disease. Here is a pooled analysis which was presented a few years back I was involved with, from data from both randomized phase 3 studies, COMFORT-1 and COMFORT-2, showing longer term overall survival with ruxalidnit. Over time, we've learned that this is genuine. It was now one of the initial goals of the study. I think it's probably multifactorial, improvements in spleen and symptoms, probably an impact on decreasing the likelihood of progression in the disease. It's also been shown that if individuals came off or discontinued ruxalidnit, that their survival was worse, particularly if they had clonal evolution. And this is, I think, both an absence of the benefit received by JAK inhibition, as well as, I think, factoring out individuals that responded less and therefore came off of JAK inhibition and had a higher likelihood of progression. Now, we've learned a lot about the use of these agents over time. Initially, the ruxalidnit trials only allowed individuals with a platelet count of greater than 100,000. Over time, we have learned that it can be used safely in individuals, sometimes with lower counts, and the platelet count above 50,000 has been tested in both numerous trials, as well as in the JUMP trial, which was the open access study, that again was able to show benefit in terms of symptoms, as well as improvement in splenomegaly for individuals in that range of 50 to 100,000 platelets. Here we looked at toxicity with the JUMP study, the adverse events, regardless of the relationship. And as had been seen by the COMFORT studies, anemia and thrombocytopenia being the most common toxicities that can be seen. Indeed, when we inhibit JAK2, anemia and thrombocytopenia are somewhat expected. Now, I mentioned that fedratinib is approved now as both a frontline agent as well as been used in the second-line setting. And we're learning more about fedratinib as time evolves as well. Here, this is data from the frontline study, the JAKarta study, fedratinib versus placebo, suggesting an improvement in progression-free survival for individuals treated with fedratinib over placebo. And I look at these data and think that it's logical that these are patients that are receiving JAK inhibition, they're responding, and increasingly we're seeing data suggesting improvement based on being treated effectively with JAK inhibition. Additionally, we have data that presented suggesting improvements in overall survival even in the second-line setting in the JAKarta 2 study for those individuals treated with fedratinib. So our current NCCN practice guidelines for myelofibrosis are really risk-based. You bring in all those factors to assess your risk. And in low and intermediate 1, there's stratification based on whether patients have symptoms or not. And symptomatic in that setting may begin with JAK inhibition, clinical trial, or other medical therapies. Individuals that are symptomatic, intermediate 1 risk, or with higher risk features, particularly if they have other additional NGS mutations that are higher risk, we consider transplant. Individuals that are intermediate 2 or high risk, we make that transplant decision more upfront. Is that something we need to do now or delayed? The majority of individuals will move on to medical therapy, and those with a platelet count greater than 50,000, Roxalidnit or fedratinib is recommended. Under 50, there are clinical trials. And we have a subset of individuals that are primarily anemic we may treat in a slightly different way. But let's circle back to our case, David. Again, reminding you 6-month history, symptoms, splenomegaly, some anemia, baseline platelets at 150, high risk. Naveen, what would you recommend for this patient in the frontline setting?
Well, thanks, Ruben, for a wonderful presentation, really summarizing what we see truly in the clinic. I think for our patient, David, first thing I have to mention that you and I believe in is always refer for a clinical trial if that's available and possible, even in the frontline setting. But in the absence of that, in the standard of care setting, as you nicely showed here, we would go for a JAK inhibitor as a frontline approach for this patient with high-risk myelofibrosis. And in terms of monitoring and watching out for the patient, as you mentioned, you definitely are watching out for cytopenias in the beginning. So cytopenias can worsen before they improve. So frequent lab checks, frequent provider follow-up, particularly in those first 1 to 3 months where the anemia and the thrombocytopenia can be most exacerbated. And then finally, dosing of the JAK inhibitors, particularly with the Roxalidnit, as we know, is based on the platelets, and that's actually part of the package label insert. So Ruben, I would say go for JAK inhibitor as a frontline approach, consider clinical trials.
Wonderful. So you start them on this, and by package label at 150,000 platelets, they'd be 15 twice a day. How soon would you be rechecking labs? And let's say that 9.4 became 8. Would it make you change anything in terms of the hemoglobin?
Oh, wow. So important. I think that, so you've started your JAK inhibitor, really ideally you want to check labs very frequently in the beginning, maybe even as frequent as once a week for that first month, and then maybe you can space it out from there. With the anemia, I actually expect it. I expect it with the Roxalidnit. So we do know that patients can get into anemia, maybe even need transfusions in the beginning. So I personally would not necessarily change the JAK inhibitor or the therapy in the first month or 2, but know that the anemia can happen. Follow it closely, replace and transfuse as needed. Try to get to 3, maybe even up to 6 months for peak effect before making that decision.
I think it's really a key point, Naveen. Initially, I think we were very timid about the anemia. And when Rux was first approved, many individuals ended up coming off of the drug very rapidly because it dropped the hemoglobin. Now we've learned a bit over time that can happen. It does not necessarily lead to any worsening of long-term outcomes. In fact, if anything, if they're able to stick it out and stay with the drug, they're probably better off for the long term. Well, what we're seeing is that there may have been really an overcorrection, and there's a lot of underdosing that is occurring. A lot of individuals on 5 twice a day or other doses we don't think are that helpful. For individuals, I would suggest if they feel compelled to start at a lower dose than the product label, and over time, I think I've become much more comfortable with the product label and just supporting them. But if you start them lower, let's say at 10 twice a day, the key is then to increase the dose, over time, to really try to optimize that response. How soon, for those patients that you're seeing over in Houston, do you think is a good time to consider really a dose increase?
Yeah, well, I agree It's such an important point you make, because in addition to what you said, we're starting to see that the dose matters, and that the dose may be proportional to the spleen response and then therefore the overall response of our patient with MF. So our approach is exactly what you said. Whatever dose you start, aim to titrate quickly, rapidly, based on these platelet counts, and try to get patients to what I would consider their maximal or optimal dose. So no time frame except to say do it quickly and get to that maximum dose. Try to get that spleen size reduced as quickly as possible, and then you can start to see the outcomes based on that.
Wonderful. Well, let's pivot a bit. Let's say David does not have the response that we wish. So again, I think the greatest likelihood is that the patient's going to have a good response in terms of spleen and symptoms. And there is a subset that may not achieve that, or they may achieve that, but over time, either lose that response or potentially have a change. So let's say David was started on Roxalidnit, but it had really a suboptimal response to Rux for improvement in spleen or symptoms, or maybe had progressive anemia or thrombocytopenia. There are some other options that are evolving in trials. Let me cover a couple of the other JAK inhibitors. And that I do think as we move forward in the future, I think we'll be looking at patients having an optimal JAK inhibition strategy, and then a subset will likely then be on combination therapy. But in terms of the rest of the JAK inhibitor portfolio, first let me discuss momelotinib. It's a JAK1 and JAK2 inhibitor, but also inhibits ACVR1, which is inhibiting hepcidin, and we feel that that may be part of its mechanism for helping to improve anemia. In the Simplify-1 and Simplify-2 studies, there was improvements in spleen and symptoms, as well as a potential for improvement in anemia, both in the frontline setting and in the second-line setting. And currently is being tested in a second-line study led by your colleague, Dr. Rostovchik, and I, in the second-line setting. We have analyzed those data and were able to show, interestingly, that the achievement of transfusion independence was associated with improved overall survival in patients receiving momelotinib. We thought that was pretty interesting data, that not only was there an improvement, but it was associated with improvement in survival. Is it because of the increased red cells, oxygen carrying capacity? Is it a surrogate marker of a decrease in inflammation or hepcidin? I think mechanistically we can't answer that, but it does, I think, help to further validate the data that we're seeing that JAK inhibitors can impact survival. We saw it with Rux, a suggestion with fedratinib, and now both a suggestion with momelotinib, but an association with improvement in transfusions. Pacritinib is the other JAK inhibitor. It has shown safety in individuals with marked thrombocytopenia, inhibitor of JAK2, FLT3, but also IRAK1, and is having good activity with, let's say, the cytopenic phenotype of myelofibrosis, with good data from the PERSIST-1 study, PERSIST-2, that included individuals all with thrombocytopenia and improvements in spleen and symptoms, and now undergoing testing in the PAC-203 study and the Pacifica study. So anticipate a potential approval in the near future of this agent, particularly helpful for MF patients with the cytopenic phenotype. So let's circle back. What if this patient has this suboptimal response? what would you do? Naveen, would you switch to one of these other JAK inhibitors, likely on a clinical trial, or consider other clinical trials, or would you jump to transplant?
Right, Ruben. Again, fantastic information. So a little bit of all of the above, right? So luckily now we have several options for our patient David, and I think you nicely characterized them. I do want to emphasize to our audience that we do have the option for these three, right? So going to another JAK inhibitor, there, if you started out with Roxalidnit, you do have the fedratinib as an approved agent, but then you also have the clinical trials with several of these other JAK inhibitors, so that's great. I do want to emphasize, and I'll show data here in a moment, on this new emerging area, so-called add-on or add-back strategy in the suboptimal responder. And so that's another big option for our patients, where you add in a second agent that's beyond JAK inhibitor, but then keep the JAK inhibitor that you're on. And then, of course, finally, you do have to think about stem cell transplant in this young, fairly fit person, 64, who has high-risk disease. So I'm going to cheat and say all of the above, because all of those are options, Ruben, and I'd love to hear your thoughts.
Well, I agree with you entirely. As I share with folks, how do you try to decide between them? I think the individual that is not worse with their disease, but is not responding, is very appropriate to consider a change to a different therapy, as well as be certain that you're on the right dose or don't have another strategy. The individual that clearly has progression, particularly with markers towards acute leukemia, I find that that is the single strongest driver of advancing that transplant conversation. Now, let's take a slight variant. Let's say he had a good response for 4 years, but now has progressive cytopenia, splenomegaly, and refractory disease. So how do you approach this? And these are many of the sort of consults you and I see.
Yeah, it really is. So this is a good question, because this reflects what you and I are seeing in the clinic. Here, after several years of, let's say, maximizing JAK inhibitor therapy, again, there is the same options of switching to a JAK inhibitor, going to transplant, but at this point, our patient is now nearing 70, has been on JAK inhibitor for 4 years plus. So in my opinion, now you can go for clinical trial at this point for these add-on or combination studies, which, in other words, allows our patient to either stay on their JAK inhibitor, add in the second agent, or remember, some of these are a completely new agent at this point. The thinking being that you've had a maximum time on JAK inhibitor, and now it's time to, if not change the strategy, add to the strategy. Ruben?
No, agree entirely. I think these folks, I think it's very important when there has been a change like this, the change can be heterogeneous. So I think eating a bone marrow is critical, again, to help separate, is it really more evolving toward AML and brings in that portfolio of thoughts, transplant, different trials, perhaps even hypomethylation, or is it truly just kind of a loss of benefit to the JAK inhibition? In which case I'm much more inclined to switch to a different JAK inhibitor. So I think which trials I'm interested in, as well as what sort of options we'll consider, will depend a bit on what is the phenotype of that progression, and kind of how we got there as well. Also want to be certain that again, we had really optimal dosing, et cetera, of the agent that they had been on, to really be sure that it's the right thing. Deciding on recommendations for what to use in this patient in the second line setting, might include some of the new options that are available to us. Naveen, why don't you take us through some of those new options?
Well, thank you, Ruben, for some amazing educational information. And as you mentioned, now we're moving into the era beyond that of JAK inhibitor monotherapy into the rational combinations. And so with the remaining time we have, I'd like to give you an overview of several of these active and exciting agents now in clinical trial. Well, the first part of this is that we have so many new clinical trials in our field that we won't even be able to cover all of them. So this first slide, can we make it better? JAK inhibitor combination shows kind of a sampling of that, and you and I had mentioned some of these. At the top of the slide, we mentioned the HMAs, azacitidine and decitabine, that our groups and others have looked into adding to the JAK inhibitor, particularly in those with accelerated or blast phase MF. There are some of the newer agents such as luspatercept and sotatercept, which our groups have really investigated in patients with MF to either add on to JAK inhibitor or stand alone to particularly help with the anemia, another urgent unmet medical need, and then so on and so forth. There's some of the older agents, some of the IMiDs, interferons, and then some of the newer agents with BCL-XL inhibition with navitoclax, and then bromodomain inhibition with the novel agent CPI-0610. So I'll show you some data on some of these exciting new combinations. So Ruben, first is the luspatercept story, which you've been a part of from the beginning, which really talks about this urgent unmet medical need in the patient with myelofibrosis, which is that of transfusions, anemia, quality of life. And the luspatercept is now actually available. It's actually approved in several other settings, including a subset of myelodysplastic syndrome and beta thalassemia, and now actively being investigated in myelofibrosis. This slide kind of shows the top line important data from our recent colleagues' presentation, which really shows 4 subsets. On the left are patients who are not receiving JAK inhibitors. So these are patients not on Rux, the luspatercept agent alone, clearly showing benefit here in terms of decreasing transfusion needs. On the right are the 2 cohorts in patients who are on JAK inhibitor, those not needing transfusions with anemia, those transfusion-dependent anemia, and then again, pretty striking results here. So over time, we'll be following for the durability of this and trying to see what the other endpoints will be in terms of quality of life, decrease in transfusions over time. So that's the luspatercept agent. Another agent I wanted to highlight is the navitoclax agent, which I'm helping to co-lead with our colleague, Professor Claire Harrison. This was data that I showed at the ASH meeting in December 2020, showing that this BCL-XL inhibitor, in combination with Roxalidnit in those patients with myelofibrosis with suboptimal response, is showing a very nice splenomegaly improvement in most patients treated. Out of this data set, 34 patients shown. The SVR35 best on study was 43%, so 13 out of 30, with the week 24 at 30%. In addition to this, patients were also experiencing symptom burden, response, and some reductions in bone marrow fibrosis were seen. The navitoclax agent is important and interesting. It's an oral drug, just like Rux. It hits BCL-XL more than BCL2, which most people are probably familiar with the venetoclax agent. And in this study, regardless of mutation status, there was still benefit for this double oral novel combination. Here, shown in this gene map, is that patients beyond the driver mutations, which you had mentioned very nicely, so beyond JAK2, CALR, MPL, many patients had so-called high-risk molecular mutations, and in these patients, responses were still seen. Now these, just to remind our audience, are ASXL1, SRSF2, EZH2, etc. So the concept here is that perhaps with double therapy, we're able to overcome the resistance of some of these higher risk subsets. Still further, efficacy was seen in various populations with myelofibrosis. Remember, these are all patients who are already on JAK inhibitor Rux for at least 3 months, and now they have the new agent added on. And you can see here clearly that SVR35, symptom burden 50% response, bone marrow fibrosis improvement, and even some patients with variant allele frequency reduction are all kind of clustering together, and you're seeing responses. Importantly, with every new agent, we must talk about toxicities. Almost all patients saw thrombocytopenia, which was an expected side effect of the navitoclax agent, and then there was some diarrhea and fatigue reported in over half the patients. In terms of the grade 3 or higher side effects, thrombocytopenia was the most common, followed by anemia and pneumonia, and we found in this ongoing study that the thrombocytopenia is very manageable with intra-protocol managed dose modifications. And so I think the concluding kind of remarks with the navitoclax ruxolitinib program, this add-on or add-back strategy, is that possibly we're starting to see disease modification. You're seeing inflammatory cytokine modulations over time, which are built into the study, and there's correlations with spleen and symptom response, Ruben, with some of the known cytokines that we know in our field, and then maybe even uncovering some newer ones that need to be validated over time. And so the concept is, in myelofibrosis, a cytokine-rich disease, maybe JAK inhibitor alone isn't enough for some patients and they benefit from a second agent. Very exciting data from our colleagues, Dr. Mascarenhas and others, showing the benefit, clinical benefit, of the bromodomain inhibitor CPI-0610. In these key presentations, very striking data to show that even patients with transfusion-dependent anemia with myelofibrosis on ruxolitinib have the bromodomain inhibitor added on, that many of these patients are able to convert to TI or transfusion independence along with spleen volume change. This is in the add-back setting with these promising results as shown on the slide with the TD to TI conversion of 34.4% or 11 out of 32 patients. In fact, this data is so exciting with patients that it even carries over to the non-transfusion dependent patients showing anemia response, spleen volume response with this double therapy. And both of these programs are now moving into the frontline setting in phase 3 clinical trials. And so, Ruben, as we revisit our patient David with relapsed refractory myelofibrosis, initially started on JAK inhibitor with Rux, initially having a nice response for 4 years, now unfortunately comes to the clinic, progressive cytopenia, splenomegaly, and refractory disease. What would you go for David? Are you intrigued by these ruxolitinib add-on combinations? Would you go for stem cell transplant, all of the above strategy? Ruben, what are your thoughts?
Well, I think whenever you're in this situation, you really need to investigate both options kind of in parallel. What is the best medical approach as well as the transplant issue? I think that the add-on strategies are very attractive in that patients likely still have some benefit from JAK inhibition. So I'm particularly intrigued in these settings of the approaches where we're adding a second drug in to try to regain or optimize response. I think trying to go to a single agent as second line will be less efficacious than a combination approach. I wouldn't necessarily restart the JAK inhibition just to add in the second agent, but if they're already on a JAK inhibitor, I am both intrigued by the data. I look forward to the large phase 3 studies that really help to further validate both the quantity of their benefit as well as whether we end up learning, as you're seeing with the navitoclax data, whether there's granularity as it relates to the molecular phenotype or other features in terms of selecting your next agent.
Wow, great points, and I agree with all, and that kind of helps us wrap up this session, which is the last few slides, kind of putting it all together as you and I have discussed here. So now we have the novel agents, we have the new JAK inhibitors all coming, most of these all available on clinical trials as we mentioned. So now we have to start thinking about how to put it all together in the frontline patient, so seeing the patient for the very first time in the clinic. So we've reviewed together the frontline JAK inhibitor data, ruxolitinib, fedratinib, now the two new JAK inhibitors, momelotinib and pacritinib. And now, as I mentioned, both the combination with the bromodomain inhibitor and the navitoclax, both moving into the phase 3 frontline randomized trial setting. And then even in the second line therapy, as we discuss these several add-on strategies, we have not yet seen these add-on strategies paired with the other JAK inhibitors, so hopefully we see those in clinical trials to come. And then there's a host of other agents that we don't have time to mention, but that you and I are either participating in, leading in, or supporting our other colleagues, and those include such novel agents as LSD1 inhibition with the IMG 7289, imetelstat, of course, the telomerase inhibitor, very intriguing data, so on and so forth. And so as we conclude, we have to think about not only efficacy of these novel agents, but also treatment toxicities, durability, and then once they're approved, cost and availability. And so as we think about overall survival as an endpoint in many of these patients, we have now seen, thanks to yours and Serge's work, overall survival data with ruxolitinib. You're showing us overall survival data with momelotinib, particularly in those benefiting from transfusions, imetelstat as well. And so overall survival will become a more and more important endpoint as we design our trials. And so as we think about clinical take-homes, and as I turn it back to you, Ruben, I think that we've covered some of the new era endpoints. We need to think about toxicity of the novel agents, how to best combine them, and to always think about stem cell transplant as really the only curative option for our patients with intermediate to high-risk myelofibrosis in 2021 and beyond. And then you've now nicely talked about not only the JAK inhibitors that are available, but several that are on their way, and then trying to figure out rational combinations for these. And Ruben, as I turn it back to you for your take-home points, you really emphasized to us very nicely that a lot of these things go in parallel, and I really appreciate that as an active clinician myself. Mutation analysis, transplant consult, clinical trial thinking, all these things can happen at once. They're not necessarily sequential. Ruben, what are your take-home points for this session?
Well, I think very well said, Naveen. Managing patients with myelofibrosis, it's a complex, a heterogeneous disease, which patients really have sometimes a very long course. So it really is about optimizing medical therapy. We've got two really solid options with Roxalidnit and Fedratinib. I think momelotinib and pacritinib are very exciting. I anticipate approvals for both of them, and I think we'll find important niches for each of them. So that we'll really have this setting of, how do we optimize the frontline JAK inhibition? And then, as you so eloquently discussed, we also have a really robust pipeline of other agents looking at different mechanisms of action. I think we'll learn over time, which of them do we add up front? Which do we add back in later or use as second line agent? How do those possibly intermingle with some of the other JAK inhibitors? Most of those combinations have been with Rux. Are there any differences with fedratinib, pacritinib, or momelotinib? There might be. But I think I would leave people with a takeaway really of hope. I think there is a tremendous amount of progress, a lot of sharp people all working together as a team and trying to improve options for patients with myelofibrosis. And I think we'll be able to continue to individualize the therapy further, based on their phenotype, based on tolerability, molecular signatures, and evolving data. So this has really been a great discussion. Thank you so much, my friend, for joining me for this discussion, and really hope that everyone that has participated today has found this to be worthwhile. Thank you so much.
Thank you, Ruben.
This activity is accredited by Medical Learning Institute, Incorporated. This activity is developed with our educational partner, PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/CCY860. This activity is supported by independent educational grants from AbbVie and Insight Corporation.